Well, good morning, everybody. My name is Michelle Marks, and I am serving as the Research Promotion and Oversight Committee Chair, along with my colleague, Dr. Jim Sanders. And we both would like to welcome you today to the fourth annual SRS Research Grants Outcomes Symposium, where we have an incredible lineup of speakers who have received research grants in the past few years and are going to be sharing their outcomes of their amazing work. Our first presenter this morning is Dr. Stefan Perrant, who is going to be presenting his standard investigator grant outcomes on postnatal ovine model of congenital chest wall and spine deformities. Before Stefan presents, could you please note that if you have any questions for Stefan or any of our speakers, please submit them through the Q&A feature in our Zoom. But I would like to pass it on to Dr. Perrant.
Thank you, Michelle. I hope you can hear me correctly. I'm presenting on the work that we've been doing at our institution on the postnatal ovine model of congenital chest wall and spine deformities. These are disclosures. The main disclosure, most of them are unrelated to this. We did get support from PASNA and from SRS for this. The main disclosure is that I have to recognize the work of Jesse Shen. He was a PhD student at that time doing the work on this project, and he's now a member of SRS, a young investigator at our center, so in Montreal. So we're very happy to have him, and he did the bulk of the work on this project. So as an introduction, we believe that surgical management has not been clearly found to show benefit in decreasing morbidity over in children with spine and chest wall deformities. One of the issues that we think and the lack of data surrounding this comes from stems from the fact that we don't have a good animal model. A good model would obviously find ways to mimic the deformity that we see at birth, but these models are hard to do. So we did have some experience previously in an in utero model where we were able to create earlier deformity. And then this deformity was occurring before complete lung development. But the issues with this is that we had some stillbirths. Deformity creation was less reliable, so we had some lambs that would be born without almost no sign of deformity, and it was very expensive. So what we tried to do is to go to a postnatal model. We think that we would be able to have more reliable deformity, a higher survival rate, and maybe decrease the cost. I mean, these studies are still very expensive to run, but maybe decrease the cost because we wouldn't have to create the deformity in utero, have the mother survive so long, and then give birth. So the model in theory is less expensive. But the cons is you still do the deformity in a normal specimen, and maybe there's less impact on lung development, and then timing of this is very important. So we try to do this very, very early postnatally. So instead of waiting a few months that the lambs were a little bit bigger, we would do the surgery within the first few days of life. So this study really aims to develop a preclinical model mimicking the effect of early onset deformity on respiratory function by applying a tethering technique to newborn lambs. And we hypothesize that the tethering technique applied to the newborn lamb is feasible, can produce reliable progressive chest wall deformity while obtaining high survivorship similar to previous reported studies in other older animals. So this was reviewed by our IRB locally, and then what we tried to do is to look at the feasibility and then look at lung development assessment. We did some lung assessment every month for 3 months after that, and then we used the ovine model because this was we believe a model that's pretty sturdy for this type of study. We used 8 newborn lambs and in this pilot study, and we used a new tethering technique. The technique consisted of a posterior approach to the spine, tethering the left side of the spine from T6 to L1, and then contralateral lower 6 rib partial resection. So really trying to make that spine shift towards the right side. And then all lambs were followed up to 3 months post-op. The surgery was done at 48 hours of life under general anesthesia. The tethering of the spine and osteotomy of the contralateral side was done at the same setting. And then we monitored these lambs for 24 hours post-op, and then in the lab for 1 week, and then they were sent back to the farm, and then came back for every month for their exam. The lung function was testing and follow-up was done general anesthesia and endotracheal intubation, and then was performed every month. And then the lungs were harvested at 3 months of age. These are some results. You can see that of the 8 specimens, we have several that did produce a significant deformity. The initial deformity is not so big, but the bigger it is, typically the worse it would get over time. You can see, for example, the first line here, you can see the patient or the specimen went from 14 degrees to 29 at 1 month, and then 45 at 2 months, and then 49 at 3 months. But some of them went all the way up to 64. Specimen 4 here, unfortunately, did not wake up after the lung exam done at 1 month. So this patient did not survive this and had a fairly significant deformity. You can see what the type of deformity that we were able to create here at 1 month of age. It's not the best quality picture, but you can see somewhat significant deformity, but at 3 months of age, you can see that it's really, it's a very significant deformity that was created, and this was reproducible in several lambs. So we believe that this study demonstrated the feasibility of this new tethering technique by doing both the tethering on the concave side and removing the ribs on the convex side. We believe that this is the best methods of getting significant deformities. We were not so interested in small deformities. We would really want to have large deformities. The survival rate immediately post-op was quite good. Unfortunately, we lost one animal in one of the testing at 1 month for the breeding or the lung assessment. The limitations again are by the small number of lambs, and then lung function and development still undefined with this model. We are working on a normal cohort to look at defining normal growth at 1 month, 2 months, and 3 months, and try to have some charts that we can compare to. Histomorphometric analysis of lungs is pending. It's still on the way. So we believe that this is a very interesting model. It has several advantages over the in utero model. And then we believe that we are able to create some significant deformity, and we are looking for the aspects of what this will look like in terms of impact on the lung tissue. Thank you very much.
Thank you, Stefan. That was amazing. You mentioned a little bit about the selection of this animal model. You said you felt it was one that you opted for, but can you describe why you chose it and why you?
Yeah. It's a good question. So that we did have, like, maybe 8 or 10 years ago, we started doing in utero models, and the advantage of the in utero model, we believe, is that you're creating the deformity before the animal is born. So the impact of the congenital deformity would be probably more mimicking what we would see in normal children or congenital deformity. The issue with this is that we did a few series of these, and like probably beginner's luck, but the first series we had 100% survival. And then in the second series, we had almost 50% of stillbirth. So was it because was it something that we did in the lab? Was it something that the deformity creation was too important? But we felt a little taken back at the number of stillbirths that we had. So we felt that finding a right another model that would be able to create a deformity that would be similar would be probably better. Cost was a big issue. Having the mother survive for so long and then giving birth and then bringing it all back, and then the timing of this was a little hard. So that's the second part, and then the third part is that there's other models that exist. There's Brian Snyder has a very nice postnatal model in the rabbit. I think the disadvantage or the advantage of this model compared to the rabbit model is the timing of the surgery. So the rabbit, before they're big enough so that you can do the surgery, they're almost adolescents. We're trying to mimic something that happens quickly after birth. So that window we're trying to bring as close as possible to that's why we chose the 48-hour window. So they're very small, but at least they're they're already living. So it's like, and then when you're comparing the actual growth of a lamb, it's depending on the species, it goes from 12 to 18 months. So if you come, like, the quick rationale is 1 month in the lamb is about 1 year in a child. So if we're creating deformity under a month, then we would clearly have something that would mimic something that we see in early onset scoliosis.
Thank you for explaining that. That makes sense. So a question from Teresa Bass was sent in through the Q&A. She's thanking you for your talk, and she's wondering, do you think the rib resection interfere in the results, and not only the tethering?
It's a good question. So we wanted the rib resection in the in utero model was the one that did the bigger deformity. So if you just resect 2 or 3 ribs on what we think was going to be the convex side of your deformity, this is giving you actually very good deformities. I think the tethering is more of the ribs is more helping to initiate that initial translation, but what really creates a deformity over time is the rib resection. So I think that if we continue on this model, we will probably try just removing some ribs and maybe not attach them as much. But I don't think they're interfering with the deformity. They're actually helping in creating that deformity. But thanks for the question.
Yes. And another question submitted through the Q&A. What is the definition of significant lung function dysfunction in lambs?
Yeah, so also very, very good question. So the in utero model, we published some results on the histomorphometry. You see smaller cells, you see that they're compressed, you see also that their alveolar walls are thickened. So it's difficult to see. There is some impact on the capacity of the lung and the lung tissue. There's some restrictive changes that we can actually see and measure, but they're not. We don't see 50% reduction compared to normals. Like we had some normal lambs that we did this, and it's not 50%. It's probably 10 to 15%, even with bigger curves. So, but it's also giving you a sense that the animals and humans are fairly resistant to that. But we don't see changes before we get to about 80. We see in kids, we see like it's fairly normal lung function up to 70 to 80 degrees, and then it hits like over 100. It's pretty bad. So I think that there is some capacity to absorb some deformity, and then as you get bigger deformities, but then when you get to the bigger deformities, it does have an impact.
How exactly do you measure it in lambs? Is it similar to humans?
Also, yeah. So we have this very cool mechanical ventilation that we put the patient under it. So you have to put them under general anesthesia, but then you input some oxygen and gas, and then you extend the chest cage to the maximum, and then let them recoil, and you can measure resistance to airflow. You can look at lung elasticity and chest cage elasticity. So you get these measurements similar to a spirometry test that we do in clinic.
Got it. Okay. Well, we have a couple of the presenters have questions. But one more question from the Q&A is along the animal model questioning. The quadruped model versus the bipedal model. Can you speak to that and whether you
Yeah, so that's a tough one. So and it's always these models are bipedal models would be ideal. They would be much more expensive. And to be honest, all the studies that we have done for other showing how growth modulation functions have been based on these quadrupedal models. Does it really completely translate? Maybe not, but I think that it's the best thing that we have.
Yeah, okay. All right, well, I'll pass it to Dr. Renee Castelline. Would you like to ask a question to Dr. Perrin?
Yes, thanks. Great presentation, Stefan. I was wondering if you're looking at the effect of congenital scoliosis on pulmonary development that usually originates pretty early in intrauterine life. And this is what, so that also affects the very early development of the lungs. So how do you relate that to your model?
Exactly. So that's why we try to put it as early as possible postnatal, knowing that we did some intrauterine deformities. We created some intrauterine deformities, and the impact on the lung was not. It was, unless the deformity was tremendous, it wasn't that important. We had some lambs that had very severe deformities that did not survive past a few hours. So that's where, like in the in uterine model, so they had very severe deformities. So is that something that we see? Like we don't see that often in even humans. Like a child will usually survive even if they have a significant deformity coming in. But yeah, it's a good question. I think that where we are placing this model is really early postnatal, so we're trying to get the best of both worlds. But we might not be able to completely mimic what's happening in utero.
Thanks.
Dr. Sanders, did you have a question for Dr. Perrin?
I do, Stefan. It's a great study. Somewhat along similar veins, the criticism you're clearly going to come up with is that this does not mimic any exact type of human early onset scoliosis. How are you going to respond to that in terms of how various scoliosis etiologies or specific deformities affect the lungs? Because that's the ultimate question that you're asking here.
Yeah. I think that Jim, it's a great question. I think that creating congenital scoliosis in an animal model has been done. Like if you put hypoxia for a long time, then they tend to create scoliosis. The issue is that you don't get a reliable deformity creation every time. So what we're trying to do is really create something that will closely resemble the deformity that you would get from all these other etiologies. Maybe the chest cage doesn't function the same way. Maybe we can attach differently the way we attach the rib cage to create more chest wall deformities. But these are it's our first attempt at creating a deformity that early. I think that any deformity that you see in a child will resemble somewhat what we have created, but we will not be able to do every etiology. That's impossible. Not impossible, but it would be hard to do, and especially in a reliable way. So when you invest that much money into an animal model, you want to have something that you don't want to put animals through this and not get a reliable outcome for your deformity. So that's why we try to make it as reliable as possible. But your point is very well taken. It will not mimic every single deformity that we see in early onset.
But do you think that the results are generalizable?
I think that if we are able to show, so one of the goals, the ultimate goals of this is that once we start having a good model, then we can start using techniques that we have in our armamentarium, so a vector or growing rods or magic, and see what the impact on lung development after that happens. So if you do a surgery early, the case for doing a surgery earlier than later is that you would protect some of those alveoli that are squished. So if you break them up, or you open up you do an opening thoracolplasty, then maybe you're saving some of these alveolar. But my concern is that, are we only stretching the already in existing tissues? So and should we wait until the end and not do this procedure too early? So like one of the ultimate goals is to have this model show that there is some impact on the alveolar tissue and number, and then see if by doing surgery early or late, do we get the same impact on respiratory function. So I think that this is the ultimate goal that we have with this model.
Thank you, Stefan. That was an amazing presentation, and congratulations on your research work. We're going to need to move on. If you're just now joining us, welcome to our 4th annual SRS Research Grants Outcomes Symposium. Our next speaker is Dr. René Castellane, who will be presenting his research work from a standard investigator grant on the 22q11.2 deletion syndrome as a genetic model for idiopathic scoliosis. Welcome, Dr. Castellane.
Thanks, Michelle. I hope you can hear me. And can you hear me?
Yep.
You can hear me. Yes, because I was on mute earlier. And I hope you can also see my screen. This is the title, and I want to thank the organizers for allowing me to present this this material to you. And I'm looking forward to your input. Yeah, here we go. So these are some disclosures, none of them related to the topic of this talk. And these are the people that really made this possible. In the left corner, Steven de Reuver. He's a former PhD student of mine who defended his thesis about half a year ago now. And he did quite a few studies, resulting in about 20 chapters in his thesis. And one of them was on this topic. Jacob Forstman is a pediatric psychiatrist at Sick Kids in Toronto, as is Elemi Breedveld, who really was instrumental and who coordinated this and really would be able to tell this story much more clearly than I'm probably able to, but I'll do my best. So scoliosis genetics has been studied for quite some time. And here you see the 3 SRS members that are probably leading in this field: Nancy Miller, Florina Moldovan, and Carol Weiss. And they have published many studies, but we have approached this, or we've been able to approach this apparently from a little bit different angle. So this is the letter that told us that we had received the grant, and this is the thesis by Steven. And if anyone of you is interested in learning more and also going over the methods for this study a little bit more in depth, then please send me an email and I can send you the PDF of the thesis. And chapter 17 is this study. It is submitted, but not yet accepted for publication. So a term that needs to be explained to some, at least it was not something I use every day, but a single nucleotide polymorphism, or abbreviated SNP, is a variant in the genome at a single base position. And it can help explain differences in susceptible persons in a wide range of diseases across a population. So why this interest in the combination of 22q11 deletion syndrome and idiopathic scoliosis and schizophrenia? That is because maybe on a philosophical level, schizophrenia is a disturbance of equilibrium during adolescence, as is idiopathic scoliosis. But more importantly, the two really share a strong independent genetic risk factor, and that is in that 22q population. We did a Swedish general population study a couple of years ago that showed a modest association between AIS and schizophrenia. And of course, the central nervous system has been implicated in AIS etiology, and some genes from GWAS studies into scoliosis are also related to neurodevelopment. This is that 22q11 deletion syndrome. It's a microdeletion, relatively common, at least in the microdeletion world, it's relatively common. It consists of 47 missing genes. It occurs in about 2,000 live births, and it holds a 20-fold increased risk for both scoliosis, and that is AIS-like scoliosis. It's not AIS, but it looks very much like AIS in its initiation, in its curve pattern, in its progression, in its overall behavior. And it also has a 20-fold increased risk for schizophrenia. So something is in that area. As I said, a couple of years ago, we published this study. We did that in the Swedish National Patient Register. We don't have a patient register in Holland that would function like that, but Hans Strop and his group were able to really help in this study. And we studied about 4,000 Swedish adolescents with AIS and about 400,000 controls. And they were all followed until the date of schizophrenia. That is hospitalization for schizophrenia. So that's a more severe manifestation. And the follow-up was about 10 years, 9.5 years. And the prevalence of schizophrenia in the AIS group was 0.5, and it was 0.3 in the general population. So there was a modest increase in risk, but that is only for the hospitalized schizophrenia population. So for the outpatients, it could have been a little bit more, but they were not in the register. We have looked at possibilities to use this deletion syndrome as a human model for idiopathic scoliosis. There's many models around, but none of them really can go into the biomechanics of the upright human spine, and perhaps this can, but the answer is still out. And the research question for this study was, is there a genetic overlap between AIS and schizophrenia in the general population, and what is the role of the involved genes in the 22q region? So this is the method. It was based on summary statistics from 3 GWAS studies, 2 on AIS and 1 on schizophrenia. And note that the number of AIS patients is not that large as compared to the schizophrenia ones, so that introduces some drawbacks. First, the study looked at the ranking of all SNPs, all these SNPs, that are associated with AIS and schizophrenia, and based on their significance and analyze overlap. And I hope I'll be able to explain that more clearly in the next slide. The second part was to look at the overlap in gene networks between AIS and schizophrenia based on the most significant SNPs that were found in the first part. And the last question was, what biological pathways correspond to the SNPs that show this significant overlap? And it was an explorative study just to see if it could generate a hypothesis. Here you see that overlap of the SNPs. This map shows the most relevant SNPs for schizophrenia on the x-axis and for scoliosis on the y-axis. And in the top right-hand corner, you see overlap. And that overlap is not due to coincidence or chance, but that is a 3% significant overlap between the SNPs that are most prevalent in AIS and in schizophrenia. There's also a significant overlap between the gene networks for schizophrenia and both the AIS cohorts. And there was also a significant overlap with the gene networks that were involved in the 22q region. And the probability of this being due to chance is about 1 in 2 million. Biopathway analysis showed multiple significant overlapping biological pathways between these genes that are related to the SNPs. And these pathways are closely related and appear to be involved in mechanisms that have to do with early brain development and cellular and neuron signaling. And this map or this chart that you see at the bottom tells it all, I hope, for some. So in conclusion, in addition to sharing 22q11 as a rare genetic variant, AIS and schizophrenia also share common genetic risk variants, and genes important in both show overlap. The gene networks for both conditions overlap with gene networks in the gene region of the 22q11, and gene networks implicated in the risk for both AIS and schizophrenia indicate the involvement of biopathways that are related to cellular signaling and neuron and brain development. So thank you very much, and happy to try to answer your questions.
Thank you, Renee. That was awesome. One question that came in from one of our committee members was a difference in the AIS and schizophrenia with your hospitalized patients. If they're both rare conditions, are you concerned that this could have been underpowered and that difference is so small anyways?
I think the study was well powered based on all the power calculations that were done. And as I showed you, there were tens of thousands normal controls and no, hundreds of thousands normal controls and a couple of thousands of idiopathic scoliosis patients. But so I think it's probably a real phenomenon. The problem is that you only look at hospitalized patients, but the other problem is that there may be some unrecognized 22q11 patients involved that have not been diagnosed. So they may have been diagnosed as AIS, whereas they were more a form of a syndromic type of scoliosis, where the 22q11 disorder that they have was both a risk factor for the scoliosis that was mistakenly called AIS because the syndrome was not recognized, and mistakenly called schizophrenia because it was related to the syndrome also. My first patient with this syndrome that I operated on, I considered to be an AIS patient, and only much later I found out, because the patient was also in the pediatric department and was getting more and more of the phenotype, because it's a very variable phenotype. So I was not aware of that syndrome, and I didn't recognize it at that point. And that is one of the things that could have played a role in that study, that some of them were misdiagnosed as normal individuals, whereas they had the syndrome. So they had a higher risk both for schizophrenia-like disorder and also for scoliosis that resembles idiopathic scoliosis.
Wonderful, thank you. A couple of questions came in through the Q&A. What is your clinical definition of schizophrenia in adults, and is it different in children?
Yeah, well, I wish Alemi was here. I'm not a psychiatrist, but I think the term schizophrenia is well, it's not used by every psychiatrist anymore. It's more often called psychosis disorder or whatever. I'm not even sure of the names that are used nowadays anymore. But schizophrenia is a very heterogeneous diagnosis that includes psychosis, but most importantly also includes deterioration of IQ, of intelligence, of cognitive functions, more rapid than what you would see in the general population. So the emphasis in schizophrenia has been very much on the psychotic events, but there's much more going on in that group. And what the exact most up-to-date definition is, I would not be able to say, because I'm not a psychiatrist.
Okay, fair enough. A question for Paul Sponsiller. You use the term disorders of equilibrium for schizophrenia and AIS. This is interesting. Can you please elaborate?
Yeah. Well, that's, like I said, that's more of a philosophical way to perhaps look at it. I was thinking about the resemblance or the similarities between schizophrenia and scoliosis. Well, there are none, as far as I can tell. The only thing is you can say that both involve some sort of a disturbance of equilibrium of the growing organism, growing individual, during a very turbulent phase in life. And in scoliosis, it affects the body, not only the spine, but much more, I would say. And in schizophrenia, it involves the mind. So for some reason, there seems to be something in both disorders where a volatile and somewhat tricky equilibrium, because I think the human spine is a tricky construct where equilibrium is challenged continuously. And it may be a surprise that so few people develop scoliosis, perhaps that's a way to also look at it. But also the brain and the mind is something that is challenged constantly, and especially during that period of puberty, both systems are challenged. So that's what I sort of, on a more informal note, mentioned in the introduction. But I don't think there's any scientific data underneath that proposition.
And because you mentioned her in your presentation, let's take up a question from Carol Wise. Did you happen to analyze males and females separately?
Wow. Did we analyze males and females separately? Yes, we did. Yes, we did. Yeah.
And is the idea that certain factors may become limiting during rapid adolescent growth? Any thoughts on that idea with regard to your data?
I'm not sure if I understand the question.
So it's and I'll let you answer that one to the Q&A. Let's take one other one. What do you think is the implication of this research on the management of AIS?
Yeah, well, none, probably none. It's part of a continuous effort to try to understand what happens in idiopathic scoliosis, and I'm very much convinced that it is a multifactorial disorder, and there's information from a million sites coming in. My interest and my focus is mainly on the mechanical part of scoliosis. I think scoliosis is very much a mechanical problem, but also in femoral fractures. Femoral fractures, of course, are very much a mechanical problem, but also their genes play a role. I'm pretty sure that people that have femoral fractures also have a gene that sort of invites them to ride motorcycles or something like that. So there's something behind the mechanical issue that plays a role in many things, but behind the mechanics in idiopathic scoliosis, there's something more that triggers whether this vicious cycle that has been mentioned by Stokes, for instance, but that vicious cycle either sets in or it does not set in, and I guess that is probably based on many different parameters, and genes are one of them.
All right, thank you very much. We're going to have to move on. Dr. Castellan, thank you so much for sharing your work on your Standard Investigator Grant Award. All right, next. Yes, thank you. Next, I have the honor of introducing Parham Razuli Nejad, who is going to be presenting his Standard Research Grant Award of Effect of Mixing Dissimilar Metals on Serum Metal Ion Levels and Spinal Implant Performance in AIS and Neuromuscular Scoliosis. Take it away, Parham.
Good morning, folks, and thank you, Michelle, for taking time to say my last name so well. Most people just butcher it. I have the honor of co-presenting this with Dr. Jennifer Urquhart, who will sort of take over at one point. We don't have anything to disclose, but I will mention that this is prelim data, so don't run out and change your practice based on the results of this study that we're going to show you currently. Spinal fusion for the treatment of scoliosis is generally done at a young age, usually in female patients. And it involves a very long construct with a substantial number of implants. These implants can be made of stainless steel, titanium, and cobalt in most cases. And these implants can undergo wear, and this wear happens two ways. One is through standard mechanical wear, meaning you have two different materials rubbing against each other over time, whether it's macro motion or micro motion. It can result in wear. And then there's also this concept of electrochemical wear. I'm not a physicist, so for me, I almost think about it as a metal rusting, but it's a process of galvanic corrosion that can occur. There are many institutions now that utilize a hybrid spinal implant construct. In our case, we have two institutions involved in this study. One uses cobalt chromium rods and titanium screws, and the other one uses stainless steel rods and titanium screws. And this is done to take advantage of the mechanical properties of cobalt chrome and stainless steel in achieving a good coronal and sagittal as well as rotational correction. The issue that we run into is that not all metals are compatible with each other, especially in any sort of a solution that has a salt in it, i.e. a human body. And in this case, if you look at this chart of compatibility of metals, what you'll notice is that titanium and stainless steel, in fact, do result in galvanic corrosion, whereby stainless steel will donate willingly electrons to titanium, resulting in corrosion of the stainless steel rod. That's not so much true when you compare titanium or when you have titanium against chromium alloys. Then there's the issue of surface hardness. So anytime you put two dissimilar metals together, you have to take into account the fact that they will have dissimilar hardnesses, and that results in differential wear of the softer material. So In this case, with those three materials, cobalt chrome tends to be the hardest of the materials, followed by titanium and then stainless steel. So for instance, if you had stainless steel rod and titanium screws, what you will see is a preferential wear of stainless. So now we have two conditions that could potentially result in wear in that construct. I will quickly mention that there is some post-processing of the rods that's done by the companies, in particular, something called laser or ball peening, which does result in changes in surface hardness, and we're still in the process of collecting that exact data from each manufacturer and actually running our own independent tests. So we hypothesized that using different materials will result in different amount of ion release, and that based on previous studies, this could be long-lasting, meaning staying there far beyond the point of solid bony fusion in most patients. And really what we wanted to see was which of the two methods resulted in lower ion release in patients, particularly at the 2-year mark. I can tell you anecdotally, certainly during my training, using stainless steel on titanium was almost a taboo in some senses, whereby it was thought to be an absolute no-no. So I will let Dr. Urquhart take over here.
Okay. So to answer our hypothesis, we conducted a multi-center prospective observational study. Patients were enrolled at 2 different centers. One center used cobalt chromium rods with titanium screws as the standard of care, and the other center uses stainless steel rods with titanium screws as the standard of care. So patients were enrolled if they had idiopathic or neuromuscular scoliosis, and they were undergoing elective posterior multi-level spine surgery. Patients were excluded if they had kidney disease, if they had no metal allergy, if they were undergoing a revision procedure, or if they had previous instruments. The surgeries were performed technically in the same manner at both institutions. Both sites used a cell saver and irrigated the wound. We did repeat blood sampling preoperatively and then at 3 months, 1 year, and 2 years postoperatively. And all of the samples were analyzed at the same trace element laboratory using the same mass spectrometry method. And then we reported the proportion of samples that were above the preoperative median reference value. We also log transformed the data and modeled the data over time using mixed models of longitudinal regression. And you can see here we had 38 patients in the cobalt chromium group and 36 patients in the stainless steel group. And this table shows the demographic characteristics. Both groups had a majority of females in the groups. The patients in the cobalt chromium group were older on average compared to the stainless steel group. And they also had a significantly larger total rod surface area. The other demographic and surgical factors were similar between the two groups. This graph shows the chromium serum concentration. The baseline values are the unadjusted values, and then the values at 3 months, 1 year, and 2 years are adjusted for the baseline value, sex, age, and total rod surface area. And we can see that the stainless steel group had significantly higher chromium levels at 3 months and 1 year. And the proportion above the median reference value is reflective of what we see in the graph here as well. And this graph shows the total cobalt serum concentration. The adjusted values are not different between the two groups at each of the time points. We do see a main effect for time, so we do see that the values are decreasing with time. And almost all of the values were above the preoperative median reference value. And then this last graph shows the titanium serum concentration, and there was an implant by time interaction effect. You can see that there is an increasing trend in titanium concentrations in the cobalt chromium group, which is the green group there. And you can see that there is a decreasing trend in the stainless steel group. At each of the time points, those values are not different between the two groups. And we see with the proportion above the median reference value that all the values were above the preoperative value. We looked at the adverse events rates between the two groups, and the event rate and the number of patients with at least one adverse event was similar. We did see that the cobalt chromium group, 2 patients had a deep wound infection requiring irrigation and debridement surgery. And we see that 3 patients in that group also had implant failure requiring a revision surgery. And implant failure is defined as screw loosening, pseudoarthrosis, or non-union. And then in the stainless steel group, there were 5 patients that had implant failure, with 1 going on to have revision surgery. Now, we took these patients there that had a revision surgery or implant failure, and we looked at their ion levels preoperatively and at 1 year. And we see there was no difference in chromium and cobalt levels. However, the titanium level was significantly increased at 1 year in the cobalt chromium group. And in conclusion, this is preliminary data, so our data collection and analysis is still ongoing throughout 2024. We did show a decreasing trend in time in chromium and cobalt, which has been shown previously, so our results are consistent with that. Our absolute values are well below the values routinely observed in arthroplasty and what is defined as being toxic levels, although we don't know what the toxic level would be in this patient population. We did show that titanium levels may be associated with revision surgery and could be a diagnostic indicator, and we're going to investigate this further. So our results do show that ion levels were more related to differences in the surface hardness as opposed to the affinity towards galvanic corrosion.
So from a personal impact point of view, this was quite meaningful to our research institution. A prospective multi-centered trial that requires data collection on patients going out 2 years generally takes a very long time to do. It takes even longer if it's disrupted by a pandemic. So we sort of had the worst case scenario here. A lot of the expenses for a study like this could be sort of piggybacked on pre-existing research infrastructure, but there are many line items that do need financial support, and I would say the grant was absolutely instrumental in allowing us to develop this collaboration and complete this study to this point. It also allowed cross collaboration, which is pretty uncommon between pediatric spine surgeons and orthopedic arthroplasty surgeons, who really have probably the most amount of expertise in the area of utilizing serum ion levels, even as a diagnostic tool and a prognostic tool. And certainly this will result in publications and further grants in the future. That's the end of our presentation. Thank you.
Thank you, Jennifer. And thank you, Parham. And congratulations on your work. That's exciting. There's a couple of questions from our Research Outcomes Committee. What are the detrimental effects of titanium when it's in the body, and how is it excreted? Did you guys look into that as baseline work for your research?
I can start, Jennifer. I mean, the truth is it's very much unknown, and it's even more unknown when you start to take into account the fact that these patients are very young and they're going to potentially have elevated levels for a far greater number of years as compared to the arthroplasty population, where this is quite a hot topic. And then the other issue is what effects it would have on a fetus. So if someone had elevated titanium levels, is this going to have some kind of a negative effect on their on gestational development? What I think in some ways the results of this study are quite reassuring in that the levels that we're showing, even at their highest point, are still somewhere between 4 to 10 times lower than sort of non-pathological levels seen in arthroplasty. Does that actually result in changes in someone if left in place for 80 years? We don't actually know that, to my knowledge, and certainly we don't know if it has any significant effect on fetal development.
Great, thank you. did you check the immunoglobulin levels and cytokine levels with relation to the metal levels?
No, we didn't look at that.
Thanks, Jennifer. Do you think you can use high titanium levels as an indicator of failure?
At this time, we think we can. There definitely seemed to be a relationship in patients who ended up requiring revision surgery and those that had the highest titanium levels. So we have had discussions in regards to this being an actual a prognosticator of potential failure. In the pediatric population in particular, it's extremely rare to actually require early revision surgery post-standard AIS instrumentation in particular. So whether it could be a routine tool or not, I would say probably not. But there does seem to be a pattern indicating elevated ion levels in patients who end up requiring revision surgery.
Got it.
That
Okay.
I just wanted to add that really appeared only in the cobalt chromium group, though. So we need to look at that further and maybe do some sensitivity analysis where we would take out those patients and look at the titanium levels without those patients included. So we definitely have some more work to do there.
Thanks. Thank you, Jennifer, and thanks for being here. Your tag team performance was wonderful. Dr. Perron and Dr. Upasani have questions. Go ahead, Dr. Upasani.
Oh, great. Yeah, thank you. So my question was regarding some previous clinical publications have shown that stainless steel rods are associated with higher rates of infection and kind of like long-term outcome studies. And I never really fully bought that finding, because there's definitely time frame shifts. Like stainless steel rods were traditionally used in the past, and nowadays cobalt, chrome, and titanium implants are more commonly used. So I was wondering if there was a time relation with that. And that previous publication is kind of different from you guys, what you guys just showed. I was just wondering from your analysis, is there some thought or connection between galvanic corrosion and infection in these patients, or how do you look at it?
That's a tough question. I'll let Jennifer take that one.
Okay.
No, I'll give you my thoughts, and then Jen can share her thoughts as well. There's still a lot to this. So, for instance, some metals, when they undergo galvanic corrosion, their oxide form is actually harder than the pre-existing form. So, but it does result in different surface materials, and I suppose you could hypothesize that some surfaces may be more compatible with biofilm formation. But like there's nothing in our study that could result in explaining whether there would be a relationship with infections or not. If you notice, the infection rate in the cobalt, chrome versus titanium group was higher in our study, but it's an unfair comparison because just to give you some insight, it's only one of the centers that had adult contributions. So the center that does stainless steel and titanium is strictly a pediatric hospital, whereas the hospital that uses cobalt, chrome, and titanium is both a pediatric and adult hospital. And the deep infections were by far much more common in the adult population, and that relates to patient factors, and that's well known that adults undergoing deformity surgery have a much higher infection rate than the pediatric population. So once again, this is prelim data, and for final publications, we would do sub-analysis of all this, excluding adults as part of our analysis to make sure that that's not a major contributing factor. But I mean, to go back to your question, I don't know the answer. Jen?
Yeah, I don't know how to answer that question either. In terms of infection, I mean, there are other studies that do look at the release of what was for the stainless steel. It was chromium ions initially, and that happens during the surgery. And then, you get sort of a release from the electrosurgical dissection part. And so you're getting some of the metal debris left in the tissue, which can sort of result in inflammation and that kind of thing. But we didn't, further look at that, and both sites used the same techniques to kind of standardize that.
Great, thank you.
Okay, sorry, we're out of time. Stefan, you're going to have to send your question through the chat. We have an important video message that will be a pre-recorded message that'll be played now from Dr. Michelle Wellborn.
Hello, everyone. I'm Michelle Wellborn, and I'm excited to have you join us at the SRS 4th Annual Research Grant Outcome Symposium. Today, I'm going to talk to you about two of my favorite grants. First, we'll talk about the Biedermann Innovation Award. This is a 2-year grant of $25,000 a year, so a total of $50,000. You need to be a young, active, or candidate SRS member, and you need to be under age 45. The research needs to have some sort of clinical emphasis and can be a clinical study or a translational study, though ultimately innovation is the key to these grants, and they want you to look at things differently. As the focus is on innovation, it's important that this is a new study and not one that's currently underway. Recent recipients have focused on wearable technology, predictive modeling, and growth modulation. Next, we'll talk about the Cottrell Foundation grant. This is also a 2-year grant for a total of $50,000. So again, $25,000 a year. The focus here is on pediatrics and on deformity specifically, and potential mechanisms for that deformity and/or its progression. You do not need to be an SRS member for this grant, but you do need an SRS member on your grant. There is no age limit for this grant, and many of the previous recipients have used this as a catalyst to earn larger grants. Here, the focus is again more mechanistic, but can be approached from many different directions. Because this is a basic science grant, applicants will need a team with a proven track record. Preliminary data is a big bonus for your application, and it's important that what you propose is feasible. Recent recipients have focused on genetic mutations and hormone responsiveness, our body's response to metallic debris, and looking at disc stiffness and how its ability to predict who is at risk for scoliosis. I hope this information helps to elucidate these grants and encourages you to apply for them. Please feel free to reach out to any member of the SRS Research Grants Committee or the SRS administrative staff for more information about these. Thanks so much and have a wonderful day.
Thank you, Michelle. We miss you. Wish you were here, but we loved seeing your face and hearing about those wonderful grant award opportunities. I'm going to be passing the baton on to my colleague, Dr. Jim Standers, who's going to moderate the second half of this symposium. Thank you again for this opportunity.
Well, Michelle, thank you for your leading on this first portion of it, and I'm going to assume the reins now for the second portion, and we're going to have two different type of grants. The first one is a directed research grant, and it's going to be by Dr. Javier Pizones, self-perceived health status and healthcare consumption of idiopathic scoliosis patients treated more than 20 years ago. Javier, looking forward to this.
Oh, thank you very much. Thanks for having me here. And I'll start. So our grant was directed as a research grant, as Jim just said. The title is Self-Perceived Health Status and Healthcare Consumption of Idiopathic Scoliosis Patients Treated More Than 20 Years Ago. So the acronym we sought for this was HISTORY. H is because of health, and then IS is Idiopathic Scoliosis Treatment. So we call it internally the HISTORY Project. We have nothing relevant to disclose. So despite all the existing literature on specific long-term impact on AIS surgery and its treatment into adulthood is poorly understood. Most of the studies that we have right now were conducted more than 20 years ago and using mainly Harrington devices, and they come from short series with high percentage of missings. So we did promoted by the ESSG, the European Spine Study Group. We did a structure of this consortium that conveys 9 European centers. And then we have a center in Japan, another one in China. There's another center in India and 1 center in the US. So all in all is 13 centers, 9 countries, and 3 continents, or 46 to 50 people involved in this project. First thing we did is we organized the executive committee. who meets monthly. Then we have a steering committee with 7 of the most relevant PIs. And then we meet every 6 months. And then we have a general assembly where all the participants participate in these meetings. This is a short summary of the people involved. You see, it's a very busy slide. There's a lot of people working in this project, fortunately. So the general objective was to understand the long-term, more than 20 years outcome after treatment for AIS in the surgical field, in a non-surgical field, and then compare these 2 cohorts with the general population of the same age, gender, and comorbidities. There's 2 primary objectives. One is to analyze what has happened with the surgical and non-surgical patients at baseline and currently right now, and then compare those 2 groups with the general match population. And then as secondary objectives, we wanted to identify predictors of long-term surgical outcomes, and then identify geographical and cultural differences with all the countries that we have. Inclusion criteria were those patients having adolescent idiopathic scoliosis more than 20 years ago, either surgical or non-surgical. We put as an inclusion criteria that the curve angle of the first X-ray or the baseline X-ray should be higher than 40 degrees, so we can really compare those cohorts being surgical and non-surgical. And then the minimum was 20 years follow-up, although we have patients over 30 and 35 years follow-up, fortunately now recruited. And then with current contact information available, for sure, we needed to go through all the charts of all patients from the 80s and 90s and then recruit patients. And that phase was difficult and is being difficult right now. So as you see here, we would do is ambidextrous. So firstly, I would do a retrospective study of the charts of AIS patients in the 80s and 90s, get the surgical ones and see how they were pre-op and how they were post-op. Regarding, we will see the variables in a minute, but regarding radiographs or surgical assessment. And then in the non-surgical group, we took X-rays from the last assessment in the adolescent period. And then we will do a prospective cross-sectional study on how these patients are right now, currently, both the surgical branch and the non-surgical branch, and then take people from normal population and how they are currently right now, match these 3 different groups, and then compare results. These are the main variables that we are analyzing. For sure, we have demographics and comorbidities. We're using all the prompts, all the typical prompts, SF36, ODI, SRS22, the typical one types. Radiographically, we're looking at X-rays, and we're also ordering lumbar MRIs in the current population. Then we do clinical photographs of all the patients in 4 views. 2 lateral views, 1 posterior view, and an Adams, the flexion view. And then neurologic status and spinal mobility. And in order to compare these to the general population, we see the healthcare consumption, the resources, the sleep wellness, and the physical activity. This is the summary of all the variables that we're taking note of. Data analysis. Firstly, retrospective, we would like to see if both cohorts are matched and are comparable. Second, the cross-sectional data on non-surgical and surgical patients. So how are these patients currently right now in terms of prompts and radiographs, what are their concerns, and then compare this to general population data. This is the chronogram that we set. This study started in 2022 in April. So we wanted the first 6 months to contact all the centers and do the RBs and approve and all the agreements, and then found the database and all that stuff. I will tell you right now what happened to those 6 months. They have extended quite longer than we thought. The blue arrow is where we stand right now. So we're collecting data. We have 2 years to collect the data to do the recruitment. And the last 6 months, that will happen next year, before April 25 is for the data analysis and early abstracts. So this is an update of how we're doing right now. We don't have any conclusions, any results to show. I'm just going to tell you how the procedure is going. Almost all the centers are IRB approval, but we still have 2 pending centers in the UK that we're still fighting with the lawyers because of agreements, and that has been going on for 20 months already, almost 24, almost 2 years, and they're still in progress. The rest are finalized and are moving forward. So first we did that, then we structured the steering committee, we conform all the formulars, then we built the database. That was in the first 6 months, and then we start recruiting patients and local coordinators. We actually did a training course of local coordinators in the first year, and then we repeated in the second year because some local coordinators changed. In the second 6 months, we did 15% of the recruitment, and then we assigned an organization that is going to monitor our data. And then the database was completely developed, and every center had a username and a password. We see here in green in October, the last thing we did is starting monitoring in October. So auditing all our data. We developed the clinical photo analysis tool that we didn't have in order to all the centers be homogeneous. And we are 40% with the recruitment. We still have 1 year to go, 6 months for recruitment and the rest for analysis. These are the different centers and the divisions on how they're doing. The 2 promoting centers, which is Barcelona and Madrid, we have done a previous pilot study. That's why Madrid and Barcelona has more recruitment than the other centers. These are the numbers in raw. From you see in the second column, the pink one, the committed number of patients. We wanted to recruit 400 from surgical branch and 400 from the non-surgical branch. Up to now, we have 313, mostly surgical, and we're struggling to get those non-surgical patients. We have 53 up to now, so we are 40% on the recruitment percentage. And lastly, the difficulties that we are having with this very big project and a lot of centers involved. It has taken more than 24 months to have all the RBs and then legal agreements, and still 2 are pending. We're facing problems with collecting baseline x-rays from the 80s and 90s. So some of them, they don't have x-rays, but we have charts with the Kobe angles and T5, T12, all that kind of stuff. We have most of them have available the coronal x-ray, but it's very difficult to find lateral x-rays. And then we have to remember that in the 80s and 90s, no one took care of the lateral views. We just used coronal. And then we had difficulties in recruiting the estimated non-NOP patients. We have a main center in Barcelona who's driven by Manuel Rigaud. He's a member of the SOSORT, and he's only doing non-op patients. And he committed to the 150, and he has the 150 charts, and he has already contacted those 150 patients, and he's doing the recruitment, and this is going to be a big center for us. PI from some sites have gone through unexpected circumstances. We have changed PIs, we have sick leaves, we have legal issues with agreements, and then we have changed a couple of local coordinators. That is why the training of the coordinator has gone on and on. And actually, we have a website with all the instructions. If we have any other changes, we have structured that too. And the last slide to tell you the next issues to cover. We're in the process of obtaining the national registry information for normal population, because we don't have a cohort or physical normal population. We're going to have this from the governmental information. Now we're planning how to centralize the MRI analysis, which is going to be done in India. And we are checking out how to send them all the MRIs that we're doing. And we try to foster the recruitment because we have only 6 months left to close.
Javier, thank you very much. We're We're going to cut some of the discussion a little bit shorter for this presentation simply because we need to make up for time for people to get off. But Javier, I'm going to at least ask you a question that in comparing operative and non-operative patients with scoliosis, you face the challenge of various curve types. Is there any power analysis that's been done for that, lumbar versus thoracolumbar versus thoracic, where the likely invertebra would be and how that's going to affect the results? And are you going to have enough numbers at the end to be able to actually do that analysis?
Yeah, thanks, Jim. Yeah, for sure. I think so. We didn't do the analysis between the different double or triple curves or whatever. We did it in a general population. The power analysis was done based on ODI changes, which is 12 points in the ODI, and that we needed 70 patients in each branch. So only for ODI will be good with the numbers that we have. Now we have to check what happens with the ASRS-22 and the other questionnaires. But by far, we went too far because we were expecting 30% of non-recruitment, so of not getting the patients. So I think we're going to have numbers enough.
And there's a pre-asked question from one of the panelists here is, will there be criticisms that there have been changes in the surgical techniques since 20 years ago? And what are your thoughts in terms of how generalizable this will be to current techniques?
Yeah, the good thing is that having 400 patients surgically treated and needing only 70 or let's say 100 to make the numbers, we can divide the cohort once we have all the data, and then we can do the first generation, second generation, and third. Maybe we can do a Harrington hybrid and then total screws. We can do that. And of course, we can also do more between 20 and 30 years and more than 30, or we could do a population over 60 years right now in the current or 30. So if we have big numbers, I think we're going to be able to do a lot of, mixing.
Excellent. Javier, thank you very much. We're looking forward to the results of this truly landmark study, and we appreciate the hard work on this. With that, we're going to go on to our next presentation, and this is, as you've just learned about, the Biedermann Grant. This is a Biedermann Innovation Award, and Dr. Vidyadhar Upsani, or Salil, is going to be giving us the presentation. Salil?
Excellent. Thank you. Thank you for that introduction, and thank you for the opportunity to present on this panel. This presentation is titled Defining the Forces Involved in Spinal Growth Modulation. My disclosures are shown here, nothing relevant, but I really wanted to take this opportunity to thank the Biedermann family for their continued support for the Scoliosis Research Society, as well as all of our research. I've really had the opportunity to spend a lot of time with Marku, and he's just a fantastic human being and very excited about innovation and development in how we treat our patients. So thank you so much for all your support. So as a little bit of background for this project, we've talked about all the different factors that go into the development of idiopathic scoliosis. Obviously, we still haven't figured out what exactly is the root cause. However, there is a common deformity that has been observed, and the concept is that there's asymmetric growth that happens during puberty that results in overgrowth of the anterior spine, resulting in that figure shown in the middle. And instead of the child having the head as far behind the pelvis, this three-dimensional buckling of the spine occurs, which centers the head over the pelvis again, resulting in the three-dimensional deformity that we've used to seeing. But the root cause is this anterior spinal overgrowth, and a couple different treatment strategies have evolved to deal with that asymmetric growth by either distracting the posterior column to help the posterior column catch up, or by applying some compressive forces to the anterior column to help that side slow down and result in more balanced symmetric growth. And a lot of this is based on work performed by Stokes. This is kind of a summary of a lot of these animal studies that he had done to put dynamic compression or tension across growth plates to show that you could actually play with the Hütter-Volkmann law and speed up or slow down endochondral growth. And interestingly, if you look at it, vertebrae or other bones from multiple species, rats, rabbits, and calves, as shown here, there's actually comes down to a pretty similar amount of pressure that you have to apply to the growth plate to be able to change how much that growth plate is growing. So just a summary here on the left-hand side with the vertebrae, you can see that about 0.2 megapascals, which results in about 100 newtons of force being placed across the growth plate. So when I was a medical student and resident at UCSD, I had the opportunity to work under Dr. Peter Newton, and I received a T32 training grant through the NIH. So I spent 2 years during residency just focused on research, which has really influenced my life and career. And this is a lot of that work that was done during those years. So we did a lot of the initial preclinical animal studies with this tether model concept in pigs to show that we could actually modulate spinal growth. Obviously, in pigs that have straight spines, we're creating spinal deformity, which is shown in that upper image. And we're able to accomplish this without putting unnecessary forces on the disc and preserving disc health as well as spinal motion. And that work was published throughout the years in a number of journals. And during those studies, we actually did look at the amount of tension that was placed on the tether during growth modulation in the porcine model, and we're able to see differences in how the spine was able to respond. And since that time, the use of VBT has really picked up in humans and has been shown to be effective in terms of maintaining motion, reshaping vertebrae by modulating growth using the Hütter-Volkmann law. But for that to happen, you do require a significant amount of growth potential of about 2 to 3 years in adolescence. However, if you do have that with EOS imaging and biplanar slot scanning images, we've been able to show that you can make significant changes in the vertebral body, especially at the apex of the deformity, to help this asymmetric growth get more balanced. However, the outcome studies have shown that more than 50% of patients who undergo the tether procedure do experience some form of tether breakage. At least that's as much as we can identify at this point. And that a lot of these procedures do end up requiring revision surgeries or ultimately go on to spinal fusion. This data at the bottom here is recent data from the HARM study group showing a survival as defined by a no posterior spinal fusion or a Cobb angle less than 50 degrees at 5 years out of about 60%. So a lot of these patients are undergoing revision procedures. So in an effort to make this form of growth modulation surgery a little bit more consistent and define the forces better, this project was broken up with 2 purposes. So one was to correlate vertebral body tether tensile forces that are required to change spinal growth in patients, so clinically. And the second part was to quantify those forces exerted via VBT through a benchtop testing model. And for the second part, we had some collaborators from Boise State. Dr. Erin Mannon and her group helped us out tremendously with the biomechanical model. So for the first part, for the clinical study, it was a retrospective review of a multi-center pediatric registry. We had all patients with idiopathic scoliosis that had right-sided scoliosis and were treated with a thoracic VBT, and that had intraoperative tension values recorded. So a lot of these patients were treated with the implant system shown there. And you can see that the tensioner has a subjective kind of scale from 0 to 5 of how much tension you're applying to the spine. So that subjective tension was recorded, and the patients were broken up into groups that had no tension applied to each individual segment, slight to moderate tension, or maximum tension. And then we made 3D reconstructions from biplanar radiographs at the first postoperative visit and then at 2-year time points. So custom MATLAB code was used to calculate vertebral height on the concave and the convex sides of the vertebral bodies from T5 to T12. We focused on those because those were the segments that were most consistently instrumented in this cohort. And then we used a generalized linear mixed model with subject as a random factor and one interaction term between intervertebral tension and the vertebral level above the tension segment to analyze the effect of tension on vertebral body growth over the postoperative period. So we had 52 subjects with 330 instrumented vertebral bodies. The mean age is shown there. Most were female as expected. The majority of these patients were skeletally immature, and we have triradiate data, we have RISR data, and we have proximal femoral maturity index on these patients. Unfortunately, we weren't routinely getting hand x-rays for standard scoring. The average height change from first direct to 2 years was 1.6 millimeters on the concave side and 1.2 millimeters on the convex side, with an average 0.3 millimeter differential height between the two sides. So again, the convex side was where the tether would be, and that's where you'd expect for our restriction of growth. So there was no difference found on the concave height change based on the amount of tension that was applied at that level, but on the convexity, greater tension resulted in less height change for all the groups, with greater differential growth observed with maximal tension compared to no tension applied to the tether. So now at least we are showing that that subjective measure of tension that you're applying to the vertebral body does seem to have some effect in the amount of differential growth that occurs in that vertebral body. So next step is to actually put some numbers to it and see how much tension are we actually applying in that intraoperative period. So to do that, we set up this biomechanical benchtop study using titanium bone screws inserted into 2 polyethylene blocks. They were fixed rigidly to an MTS machine. The screws were set 45 millimeters apart because that's about the average for the distance used intraoperatively, allowing for continuous uniaxial force measurement through the tether. The tether was affixed to the bottom screw and tightened with a set screw. And then we used the 2 clinically available tensioners to figure out how much tension correlated with each of those ordinal settings. So there's a direct cord tensioner, or there's this extension spring tube that's shown in the lower image, which is typically used to tension through thoracoscopic portals that can be applied directly onto the spine. So we had 8 orthopedic surgeons using those 2 tensioner techniques, trying to generate force at those 5 different ordinal settings from 0 to 5. And the order of generating the certain amount of force was randomized for each of the surgeons. The force was recorded over a 2-minute time period, and then one surgeon, myself, completed all the trials 3 times to look at inter-rater variability. So the raw data was imported into MATLAB, and we calculated force means, standard deviations, and confidence intervals. Inter and intra-rater reliabilities were calculated using ICC, and then the forces generated with the 2 different tensioners were compared at each ordinal setting. So you can see, interestingly, the data is very clean and linear. So this is not really what I expected, but after playing all kinds of tennis, my forearms are not significantly stronger than the other surgeons. So there is very low standard deviation in the amount of force that the different surgeons generate at the different settings from 0 to 5. T2 consistently produced higher forces, so about 62 newtons per setting compared to T1. So just as a reminder, T2 is with that extension spring. And there was excellent inter and intra-rater reliability for the amount of forces that you can generate. And then if you go back to what Dr. Stokes showed us for how much force you need to generate to be able to modulate growth, you can see that that 100 to 150 Newton force generation occurs pretty early at about the 2 or 3 tension setting. So maybe we're going a little overboard by, compressing as hard as we possibly can to generate these forces up in the 350 to 400 Newton range, and maybe resulting in some of the tether breakage that we're observing. So some take-home points: increased tether tension did result in greater vertebral growth modulation. I think this was the first study to actually quantify the forces that go into VBT. And again, this is just at time 0, right? What are we doing in surgery? There's lots of changes that happen over time. We started to look at, how the forces degenerate in the tether if we leave it tensioned for longer periods of time. And then once the child actually stands up and starts moving around, that's where, there's still a lot to study and figure out. So the current systems can reliably generate adequate tension, but we need to better quantify the forces that are applied to the spine and better understand these forces both during and after surgery. And this will hopefully help us come up with new materials, new methods to apply those forces, and then modify those forces throughout the child's growth so that we can fine-tune this technique of growth modulation and hopefully come up with non-fusion treatments for scoliosis. So thank you very much for this opportunity.
Salil, thank you very much. We have just a few minutes for questions on this. There's none that are in the open chat, and I'm just going to follow up with you then with a couple of questions here. As you start looking at the viscoelasticity, the going from the supine or the lateral position to the standing and the interposition of the disc, how do you propose creating the biomechanical models to identify what the actual tension is on the vertebral end plates?
Yeah, that's a great question. I mean, somehow we need to apply tensionometers to the tether and to the system, and then change it from supine to an upright position. So ultimately, we might need to go into an animal model type of frame, but that's where bipedal models would be really important. So yeah, Jim, that's a great question. Still not figured out, but lots more to study.
You know, when Nachemson did some of the early work on the Harrington rod, he actually implanted some rosettes into the Harrington rod to be able to see what was going on with the stress relaxation over time, and wondered if that might be feasible with actually human implants for identifying some of this.
Yeah, that'd be a great idea.
Well, we've got just a minute or two, and I see a couple of other questions here, and we'll start out with Renee Castellan.
Thank you, Jim. Thanks for that very nice presentation. One of the fascinating things in distractive growth-friendly surgery is that the disc seems to diminish in height. What do you see in the disc in this compressive system?
Yeah, that's a great point. I think because of the dynamic compression that's applied with the tether, we haven't seen too many disc changes, but we are doing a lot of studies currently. We finally figured out how to quantify the volume of the disc, and we're going to be figuring out those volume changes over time from first direct to 2-year. In this initial study, we really just looked at the vertebral body heights, but I'm really curious to see what's happening in the disc too, because ultimately that's where the early modulation happens, and I think somehow that's going to be involved in the long-term changes in the shape of the spine that we're seeing as well. So more to come with that.
Thanks.
And Michelle Marks.
Thank you. Congratulations, Salil. That was amazing. And thanks for the great words you said about the Biederman family. They've done so much to improve care for scoliosis. Amazing work. Kenny Kwan sent me a question earlier, so I wanted to pose this one for him to you. What about the relationship of the tension and the inherent flexibility of the curve? Because your model was a straight spine, right?
Right. I mean, the model was really just plastic and metal blocks. So that's to take away all the variables that you can't quantify and figure out exactly how much force you're putting. And Kenny's exactly right. Like the amount of force that you actually put into the spine in surgery is just to get the discs parallel for the most part. I think that's what most surgeons are doing, especially at the apex of the curve. And that will be different based on the flexibility of the spine. So those are exactly all the variables that we still have to figure out. But I think it helps to know that all you really need is about 100 Newton meters or 100 Newtons to be able to start changing what's happening in the endochondral ossification of the growth plate. And maybe getting the discs parallel in surgery isn't necessarily the right thing, especially depending on how much growth the child has remaining. So I guess I don't have a direct answer for Kenny, but again, more to study.
Great job.
Salil, if you can answer it in 15 seconds here, this is from Miguel Gomez. Scoliosis is 3D deformity. The VBT tries to correct the coronal. Do you think that's the reason why there's a 50% failure rate?
Yeah, I think it's interesting. I mean, we're trying to put the forces more onto the anterior vertebral body, and the concept is that if you balance out that asymmetric growth, you're going to correct the entire three-dimensional deformity. But I think a lot of our analysis with VBT using the axial imaging hasn't shown a lot of effect in the axial plane. I think there's lots of reasons for 50% failure rate, and maybe axial plane correction is one of them. But I think it's the materials we're using, the forces we're applying, lots of other reasons.
So I want to thank all of the presenters and all of you who participated this morning. That I think you can see why the SRS is rightly proud of its research program here. I would encourage all of you to please fill out the survey of the course. I took home a lot of lessons today, but probably one of the most important ones I took home was from Renee, who told me that femur fractures are a genetic disorder. So with that, I want to close and thank everyone.